So disclosure, I am a speaker for InMode since 2023, and I am a clinical lecturer at Vin University. I am not a Clarius KOL, but I am a user since 2021, and I've used more than 700 hours. And I'm not a radiologist. I'm a aesthetic plastic surgeon, and I'm here to share with you my experience using the Clarius ultrasound in my practice. So there are two parts to my talk. The first is on safety. The second is on precision. And we're going to break it out. We start with a clinical vignette. Then we will discuss ultrasound findings. And we correlate the ultrasound findings with operative and radiological findings. So let's start with the first case. So this patient came to me, 30 years old Singaporean female. She used to weigh more than 100 kilograms. She lost 20 kilograms after a sleeve gastrectomy, and her weight has been stable at 80 kilograms for the last 6 months. So she wants to do a body sculpting procedures to get a better shape. So in patients who have had sleeve gastrectomy or other bariatric surgery, the concern is of incisional hernias, because in laparoscopic bariatric surgeries, people use a lot of ports, and the ports are more than 10 mm high, and the ports doesn't get fascial closure, and these patients have poor nutritional values, and they tend to this patient have poor nutritional value, and then they tend to have a lot of intra-abdominal pressure. So the rate of ventral hernias in these patients are actually very high. And in a prospective study that was done in 2020, the rate is actually 34%, so 1 in 3. I'm very lucky that I haven't run into any case like this. So these photos are from the Clarius data science team, and they provide me with the ultrasound image of a small hernia, less than 1 cm, and of a bigger hernias, more than 2 cm. Of course, the difference in the management is that you need to have a mesh for the larger hernias. So it's very good to have this information beforehand for safety and also for surgical planning. So I went ahead and did a fleur-de-lis abdominoplasty for the patient, and this is what she looks like 1 week after the surgery. We managed to reduce her waist size by about 16 centimeters. Second case, also a bariatric patient. A little bit different because this lady lost more than 40 kg. So in this kind of patients, the consideration is different. Of course, you worry about ventral hernias, but because of the massive weight loss, you're gonna be worried about the perforators that are left behind. And these are big vessels. They're gonna bleed a lot during surgery if you're not careful. And it's very hard to do tumescent in these patients because they used to weigh more than 40 kg before. So when you do your tumescent, you put in 5, 6, 7 liters, and it almost doesn't make any difference at all. So what I do is that I use an ultrasound to scout for these perforators. So I scout for the vessels, and in areas that I see the vessels, I will mark them, and I will give more tumescence in that area. And I can measure the size of the vessels about, it's the 5 mm in diameters, and I can find it during surgery. It's pretty big, pretty juicy arteries. So I did a fleur-de-lis for her again, and this is her result at 6 weeks. Okay, next patient, also on safety. This gentleman, 38 years old, his BMI is 28. He flies all the way from Estonia, which is a country in Northern Europe. It's south of Helsinki. So he has to take a bus 4 hours from his capital here to Helsinki, then fly another 12 hours to Thailand, and then fly to Vietnam. And he came to me, and he wanted me to do 4 hours liposuction for him. So in this patient, the concern is of a clot in the legs because of all this traveling. And some risk factors, long hour surgeries, BMI of more than 25. So I use a Caprini score routinely to risk stratify this patient in terms of blood clots. And I use an ultrasound to screen for DVTs. And this is what, hold on. Phim không chạy được em? Back. Clip chạy hả? Anyways, I use a Clarius ultrasound screen for the clots in the veins, and you know all the signs you can pick up in my video. Unfortunately, we cannot play it. We see that the veins are not collapsible. We can see the clot, the echogenic clots inside the vessels. We can use a Doppler to see that there's no flow inside the vessels, and then you just turn it longitudinal. You can see the proximal collapse of the veins because it's not filled with blood. So I was worried for a clot, and I sent the patient for a CT venogram, and lo and behold, we picked up a clot about 2 cm in the legs. So I had to cancel the case, start the patient on anti-thrombolytic, and send him back to Estonia. So these are some of my rules and principles regarding DVTs. I assume that everybody who has a BMI above 30 to have DVTs unless proven otherwise with a duplex ultrasound. I use the Caprini score routinely to risk stratify my patients to avoid a risk of clots. And all patients that come to me from a far more than 4 hours flight, I will screen them for DVTs as well. So in summary on safety, we can reduce the risk of visceral injury. We can plan for our surgery better with the use of ultrasound in patients who has previous surgery before. We can also use the ultrasound to look for large vessels in patients who had massive weight loss so that we can better tumescent the area and prevent operative blood loss. And then the third point is that we can use the ultrasound to screen for DVTs in high-risk patients. And now it's a legal requirement because earlier this year, the Department of Health makes abdominal ultrasound mandatory for all abdominal liposuction case. Okay, moving on. Safety is good, but if you want to be a great surgeon, you need to be precise. And I take these pictures about 10 feet away from the lion. So if you know what you're doing, you can be close to the risk without, getting into trouble. So you need to be precise. And that's the second part of my talk. Fourth case, this lady came to me after having a mini abdominoplasty done more than 2 years ago, but she's complained that her shape is not getting better. You can see the scar of the mini abdominoplasty, and you can see that the shape of her abdomen is quite abnormal. So I did an ultrasound for her, and I assessed the integrity of the rectus abdominis. And you can, it's not very clear here, but this is her muscle on this side. It's a very thick muscle. She's, she does a lot of exercise, but you can see that it is very separated from the other side. And the measured distance between the two muscles is 32 mm. So when you compare her to somebody who's her height, her weight, her body shape, her activity level, but only 1 cm different, 2 cm different in the rectus interrecti distance, make the shape looks hugely different. So I sent her for an MRI, and on the MRI you can see the gap of about 36 mm. So in this kind of patients, if you go and you only fix the lower part, you're gonna make the problem worse. And in this fairly recent study out of Poland, I think, in fact, the most common rectus separation is in the upper part of the abdomen, above the umbilicus. And even in the patients who have both upper and lower separation, the upper part tends to be worse than the lower part. So the implication is that you cannot just go and fix the lower part with a mini abdominoplasty. You have to fix all the way from the xiphoid to the pubic tubercle, from top to bottom. And you can achieve that with a small incision if you have the equipment. And I got this retractor from Alfredo Hoyos 2 years ago, and I performed a few cases where I fixed the separation from top to bottom using a small incision. And this is how the patient looked after the surgery. And this is a long-term image. You can see the very athletic abdomen versus, the first case where you only fix the lower and you neglect the upper part. Okay, so low BMI body sculpting. I tend to see these patients a lot. Look at her, very beautiful. But she come in and she say, oh, I'm not very happy with how my thighs look. My lower body look awkward. Can you do something about it? What can I do? Her BMI is 18. So you only have a little bit of fat to work with, right? So you need to be very precise in how you place the fat. And in this cadaver study, nowadays we only put fat above the muscle, okay? No fat inside the gluteus maximus. But when you put fat in the subcutaneous area, and actually there are two zones. You can see the zones that are close to the skin and the more deeper zone, okay? And these are still subcutaneous. This is still above the muscle. But this is the zone where you want to place your fat, especially in patient who doesn't have a lot of fat. So that's what I did for her. And I'm doing ultrasound guided using my Clarius, inject the fat in the lower layer, like in the previous photo. So when you place your fat precisely in that manner, you don't get any swelling, you don't get any pimpling or any excessive redness in the gluteal skin. But best of all, the result is very long term. I only put about 150 cc, very little, but because you put it precisely in the anatomical areas that support the growth of the fat, it will stay. Okay, 6th case. I also do a little bit of face. I don't do facelift, but I do minimally invasive stuff in the face. I use FaceTite and quantum RF. And so this patient came to me. She's actually quite thin, not a lot of submental fat, but the skin here is quite loose, as you can see. So if you go and you do lipo here, you're not going to make a difference. What you need to do is you need to tighten up the skin. You need to tighten up the skin in the chin. You need to tighten up the skin along the mandible. So when you work with this area, obviously, this is the area you're working with underneath the skin, subcutaneous fat. The anatomical structure that you're worried about is the marginal mandibular branch of the facial nerve. So you can see that branch here, number 25. Let's go out underneath the parotid, go under the mandible, then it swings up. So if you're treating along the mandible, you might hit this nerve. And if you hit this nerve, the patient will have a crooked smile, and she won't be happy with you for a very long time. So you need to identify where this nerve is. And there are multiple paper studies suggesting for the best way to find this nerve. And this is one of such paper where it's described using bony landmarks to identify where the nerve crossed the facial artery. And it recommend the crossing is about 1/4 of the distance from the mesenteric tuberosity to mental midline. So it's actually quite lower down here, which I find is actually not the truth in my experience. So I don't use this method. Or you can use the danger zone concept that is well described. And if you avoid the zone 3, which is described as 2 cm behind your anterior commissure, and then your midline of the mandible, and you draw a circle around it, and you avoid that entire area, then you won't hit the marginal mandibular. But you can do that, but then you won't get great result, because this is the area that have a lot of jowling, had a lot of loose tissues that you want to treat. So I also don't use this. Yeah, you can see the marginal mandibular here, number 15. Just in that area that zone 3 described. So what do the surgeons do? So I was trained as a head and neck surgeon, and I used to do a lot of this submandibular gland excision, and we use this maneuver a lot. And we use this maneuver, we tie the facial artery and vein, and then we lift it up. And when we do that, we protect the nerve that swing up this way, the marginal mandibular nerve. So I did this a lot. So I was thinking maybe I can utilize this relationship between the artery, veins, and the nerve to have a landmarks so that I can avoid, this nerve more effectively. And that's what I did. I used the ultrasound. I mark the facial artery. Okay. I draw a circle around it. I draw 2 circles around it. This is 1 cm diameter. The bigger one is 2 cm diameter. And then I just do my treatment. I do my treatment and I avoid that area. And I go right on top of it sometimes. Okay, so again, I mark the area here. I use my incision at the angle of the jaw. I go right on it, then I pull back. Right on it, and I pull back. Why? Because the nerve is after this. The nerve is in this area up here. So I can treat from here to here without any problem. And then I go beyond, under the mandible, because I know the nerve is all the way up here already. Down here, there's no nerve. So I can go all the way over there and I treat this area without any problem. So this is a patient, 1 week. You can see the skin tightening. You can notice it right away. And it will continue to improve over the course of weeks and months. More importantly, her smile is even, no crooked smile, okay? No marginal mandibular nerve palsy. Okay, so precision is important as a surgeon, right? It's allow us to make better diagnosis so we can treat the areas of problems. It's allow us to place, place the fat, have our surgical maneuver exactly where we need it to be. Like the fat in the lower layer of the superficial layer in the butt, or when we treat the jaw without hitting the marginal mandibular nerve. So final conclusion for this talk, if there's no safety, we shouldn't do surgery. And then if we want better outcomes, we need to be as precise as possible. And the ultrasound, having a good ultrasound, knowing how to use it, will allow you to get both of these objectives and allow you to be a better surgeon. Thank you for your attention, and join me in Spain for our summit. Thank you very much.